denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Dat gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että ei hiffaa jotain juttua, mitä olisi pitänyt hiffata. Joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me, and I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
Hi, I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist. I'm proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waele and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Afternoon, good morning, good evening to everybody who is listening to this webinar. I'm Marlies Osterman and I'm a consultant in critical care at Guy's St Thomas's Hospital in London. And it's a great honor to moderate this important session dealing with practical aspects of renal support during the COVID-19 pandemic. We have the pleasure of two invited expert speakers who will touch on the challenges of practical renal replacement therapy and I'm sure explore and share their experience with us. And so without further delay, I'd like to invite Professor Pickers, who is a professor of experimental intensive care medicine at Radboud University in the Netherlands, to share us his experience with particular aspect of dealing with the high demand of renal support. Peter, over to you.
Marlies, good morning, evening or night, everybody listening. Indeed, in the first talk, I will talk about practical aspects of increasing the demand and maybe shortage of supply and personnel, and also very COVID-specific issues related to AKI and renal replacement therapy. Let me see if I can move my screens. So much of what I will tell you in the next 30 minutes is something that we discussed to great extent over the last few weeks in an AKI meeting in the Acute Dialysis Quality Initiative. And this AKI meeting is specifically on COVID-19 induced AKI and organized by John Callum, Louis Forney, Mitra Nadim, Rafi Mehta, and Claudio Ronco. And on the right, you can see the faculty of people that are actually participating on this. And normally we would have a meeting like this close to a symposium or a congress, and we would be in a nice place in the world, and we would spend a few days on discussing specific items related to some form of AKI. But nowadays, of course, this is not possible. So this meeting virtually took place on the Fuji Islands, but we were all at home and doing the meeting by Zoom. So this is one of the chairs, John Callum, everybody knows him, and this was how he did the meeting. And believe it or not, I asked him if I could share this picture, and he said, yes, of course, you can do so. So it's a consented share. So this is a virtual meeting on the Fuji Islands, but we are all at home and we are discussing every aspect of COVID-induced AKI and renal replacement therapy. And what is very important is that we are still working on what will be the considerations and what will be the recommendations. And so I have no final recommendations or figures yet, but I was allowed to share already what we have so far. So I will start with some background. The kidneys are clearly involved in COVID-19. And what we see is traditional markers, for example, your creatinine value that might go up if there's AKI, of course, but there's also a large proportion of patients that have blood or proteins in the urine, and I will come back to that later. What also is of interest is that the RNA of the virus is actually found in the kidney tissue. And so this could also have a direct effect on the kidneys or have a local inflammatory response in the kidneys. And it's also relevant to realize that renal cells actually express ACE2, which is used for the virus to enter cells. So this could also be a reason why the virus could get into the cells and have effects right there. So far, we think that endothelial dysfunction, problems with coagulation, complement activation are likely important mechanisms of the occurrence of AKI in at least a subset of COVID-19 patients. But there are also other reasons. Some of these patients have diarrhea, many of them have a fever, and of course, this might also lead to AKI if they are, for example, dehydrated. Also, organ crosstalk may appear. It's known that the kidneys are in touch with the lungs and the heart, and it's also a mechanism of AKI in a subset of patients. And also critical care interventions. We do know from previous work that if you're on a ventilator or if you receive fluids and your CVD is higher, that this might also be related to AKI. And also, of course, drugs that we use in the ICU, some of them are nephrotoxic, and again, this might play a role in COVID patients as well. And finally, there are baseline patient characteristics like age, like chronic kidney disease that's already pre-existent that might contribute. And so there's a lot of mechanisms that are illustrated in this figure that maybe if we look at the different phases of COVID-19 patients, there might be a viral phase in the beginning. Later on, when the inflammatory response is occurring, there might be symptoms and respiratory problems, and more later on in the ICU, there might be multi-organ failure. And so it's likely that in the beginning, there might be direct viral effects on the kidneys, later on effects related to the inflammatory response, to coagulation, to endothelial damage, and even later on, nephrotoxins or mechanical ventilation, etc., are also exerting indirect effects on the kidney. So if you break down the risk factors, you could do it in this way. So demographic risk factors, older age, diabetes, maybe race, genetics, etc. Risk factors that are present during admission in the hospital, the severity of the disease, possibly the degree of the amount of virus, the cytokine storm that we recognize in these patients, etc. And also during hospitalizations, again, fluid treatment, nephrotoxic treatments, etc. So there are many, many variables that are of relevance. And that's why I think there's a huge difference in the reported incidences of AKI as well as renal replacement therapy in these patients. So one of the reasons that the differences in incidences is so high is that there is inconsistent use of KDIGO consensus definition of AKI. So I think it's really important that if you are planning to publish about AKI in these patients, you should use accepted definitions of AKI. In many patients, of course, they do not have a medical history, so there's no baseline creatinine value, for example, and then it's always difficult where they came from or how it increased. We do not know if there was pre-existing chronic kidney disease. There are huge variation in temporal associations. So patients might come to the hospital early or late. The disease severity, patients are admitted to the ICU because there's still a possibility, but maybe later on there's no possibility in the ICU and very sick patients are treated in the ward or some other place. So there are huge differences in case mix, which makes it difficult, and makes it also difficult to compare different parts of the world to see how it is. In the AKI meeting, the group that was focusing on this part, they looked at all the studies that have been published so far, and they looked at the rate of AKI as well as the rate of renal replacement therapy over the different parts of the world. And as you can see that in the beginning, the first reports that came out of China actually suggested that there was a very low or even no AKI involvement in patients with this disease. But later on, we found indeed that there was, and there are still very large differences per continent. So in the USA, it might be 1 out of 3, while only about 8% is reported in Europe. Nevertheless, if you look at renal replacement therapy rates, it seems that that is much higher in Europe compared to the USA or China. So there are differences over the world, but again, it's also very much related to the definition of AKI and the indications to start renal replacement therapy, for example. The largest study up to now is a study from the area of New York, recently published. In this study, over 5,000 patients in 13 hospitals were included, all COVID-19 patients. And as you can see in this infographic, more than 1 out of 3 had AKI, divided over the different stages. And what is of interest is that the highest incidence of AKI was during admission or the day after. So very early on in the disease, as you can see here. Again, independent risk factors to develop AKI or to come in with AKI, older age, black race, cardiovascular medical history like hypertension or other cardiovascular disease, diabetes, the use of vasopressors, and the need of mechanical ventilation. And that one was the big one, because if you needed mechanical ventilation, the risk to develop, to have AKI was tenfold, over tenfold. So this is an important thing to know. Also from this study, again, the breakdown on when the diagnosis of AKI was made. As you can see, most of the patients on admission or during day 1. This is different compared to my own experience in the Netherlands, where we saw most of the patients on day 3 or 4 developing AKI. So there are huge differences when people come to the hospital, in what condition are they already, for example. So this is a summary. And again, I want to use this infographic to illustrate the very high incidence of patients with proteinuria, with blood in the urine, or both, and that might also be a signal that the kidneys are suffering already, even if they do not fulfill AKI criteria at that moment. So what about renal replacement therapy in COVID-19 patients? I think it's very important that we have to distinguish 2 situations. There might be no shortage yet of material and of personnel. And so in that case, you have to do as usual most of the times. I will break it down in various aspects. For vascular access, we suggest to follow KDIGO guidelines and to use the right internal jugular. And because one of the reasons is patients are in prone position, and you can actually, I learned also to do a line in prone position, and it's still accessible. The second choice would be the femoral vein, but in prone position, this could be difficult. The modality that you use should be based on the needs of the patients, the local expertise, the availability of staff and equipment. So the basic rule again is do as you always do and do what your experience is. I will come back to that later. One important difference that might be there is that in COVID-19 patients, and especially in the very early phase of the disease, they suffer hypercoagulation. And that means that if you're not used to using anticoagulation for renal replacement therapy, you will have to consider that, because filter lifespan will be very short in the beginning. So anticoagulation is an important issue. The next speaker will come back to that in detail. I will say some things about it in the next slides. Another thing not related to anticoagulation, but what you can do is change the mode that you are using. So using these modes, you can actually decrease the filtration fraction, and thereby the risk of clotting is less. So this is related to vascular access. And as you can see, is the femoral vein is taken for comparison, and that the internal jugular vein is not significantly different. So the ranking is, if you are thinking about permanent catheters, is not really applicable here, I think. A tunneled is best, and then femoral and internal jugular are similar, and the subclavian is last. So this is something that stays the same. And also the size of the catheter is of importance, and it's very likely that's even more important in these patients that have such a high tendency for thrombosis. So try to use the larger ones. There's a nice commentary in critical care from an Italian group that have recommendations for the use of vascular access in these specific group of patients. And one thing, and it may sound obvious, but is really helpful, is that you could have specific and dedicated vascular access teams. So that if you are an intensive care physician, you can focus on all the intensive care stuff, but you don't have to spend time on giving lines to people. So that's something that could be really helpful, and have other people that are experienced in that to help out. Another suggestion of this group was that it might be difficult because of the isolation measures to make X-rays of lines to see if their position is okay. And you could do it easy and cheap using ultrasound, for example. So that's something to consider as well. And at the same time, you need, of course, still use your infection prevention measures. It's as important as always, I would say. So in summary, if there's no shortage of people, if there's no shortage of material, the basic rule is do as you usually do. Use the same indications to start renal replacement therapy. Use the same dose, the same modality, the same indications to stop renal replacement therapy. The only thing that might be different is to intensify anticoagulation therapy. And I will say something about that now. So it's now recognized that COVID-19 patients have a very high incidence of thromboembolic events. And this is a study from the Netherlands, and they show that indeed about 1 out of 3 patients suffer pulmonary embolism or another thromboembolic event. So this is an extremely high incidence. And indeed, if you start using anticoagulation, systemic anticoagulation, so not related to renal replacement therapy, it's clear that the survival of these patients is beneficially influenced. So this is a very relevant issue that is ongoing in these patients. So what we suggest indeed is that you thoroughly evaluate their hypercoagulation prior to starting renal replacement therapy, and then you can use a stepwise approach to escalate the anticoagulation that you will use. I would suggest that if you're not using citrate, do not start using citrate during this pandemic, because it's something that you need to build experience. It's dangerous if you do it not well, and so you should not change sails in the midst of a storm. So do what you usually do, but you might want to intensify it. And also important, what we do, for example, is that we give it to the system. So we infuse, for example, heparin to the regional system, but of course it gets back to the patient, and so there's not really a difference between regional and systemic anticoagulation, and you can still measure the effects in that patient. And so you can use something to aim for in anticoagulation of that patient. So the things that I said are summarized in this table. If you look back this presentation on YouTube, you can pause it and read it as you want to. So what about if there is a shortage? And there will be a shortage if there's a second wave or in certain areas of the world. And the other thing is that there's more demand for it, but this is all getting worse if there's local global lockdown and the supply chains are also affected. So in that case, this is a really nice paper that illustrates that what you should do is make projections of demand. How much do you need and when do you need that? And it's really important, especially for renal replacement therapy resources, that if you are better in anticoagulation, you will burn down your filters less quickly, of course. And so very important to also intensify and look at that part of treatment. What they showed is that you can actually make assumptions. So you can say, well, I know what I use, what I normally do. I know how long a catheter lasts on average. I know how many nurses I need, etc. You can have specific strategies to have less resources that you need. And based on that, you can actually calculate and make a table like this, that if I have 3,000 or 5,000 patients in a week, very large numbers, I need this much of disposables, of personnel, etc. And this is really important to do in advance so that you can anticipate on what is coming and see if you will be able to do this, yes or no. So we made a preliminary figure that if there is a pandemic, there's more demand, there's less capacity for different reasons, and so there's a potential crisis in giving RRT to these patients. And so there are different goals that you would aim for. I think if you are preparing, you can start anticipating and deal and find things, start training personnel, resources, etc. If there is actually, if you are in the surge, you have to do things, and there can be a crisis. And so there can be local responses there, and regional and national responses. And we describe what you can do to actually try to maintain this treatment availability for these patients. So what also is needed is that there could be a problem that there could be hospitals or institutes that are actually hoarding materials. And so there will be shortage in another place. So it's really important that there is a multi-center collaboration or even a national overview to make sure that what is available is equally distributed. So these are things that we learned, I guess, over the last couple of months, and that we should actually be more proactive in case anything like this would happen again. So again, a long list to look back on the YouTube movie clip and all kinds of suggestions that are possible to be more efficient in the consumption of the stuff that you need. Again, it's something to look back up. So the next thing I want to discuss is that there are, of course, different modalities that you are all aware of. And this table actually illustrates what could be an advantage or a disadvantage for that specific treatment modality. And I think most of the ICUs would use continuous renal replacement therapy, but you might think that you could switch earlier than you would normally do to, for example, intermittent hemodialysis. So this is widely available also. You can treat multiple patients per day on a machine, etc. And here it is more labor intensive and you only have one machine for a patient on a day. So you have to think about these items as well to decide. if nothing, if there's a really big problem and a crisis is pending, I think we should also consider PD. This is something that we do not often do in the ICU. Nevertheless, it's widely available. There's no clotting concerns. You do not need any venous access. So these are benefits, but there are disadvantages as well. We do not have much experience with it. The patients are in prone position, which might be unhandy. And so you should have protocols if you want to do this, if there is a shortage of machines or filters. So again, it's simple, no anticoagulation needed, no filter needed. However, there's limited experiments and patients are in prone position, of course. The last few things I want to share with you is that we will also make a table of drugs that are especially important in these patients, like remdesivir, for example, and what we actually know at this moment about their pharmacokinetics. And it's unfortunate, but we do not know that much. Most of the patients that are on renal replacement therapy are excluded from trials that are investigating the clinical efficacy of these drugs. So we do not know much, and we need more information on this because 1 out of 3 patients actually suffers AKI. And so we will have patients that need these drugs and are on renal replacement therapy as well. I will not go through it, but there's not much known at this moment, and it's something that we need to focus on. What about the outcome of these patients with COVID-19 and AKI? As with many other diseases in the intensive care unit, there is a stage-dependent increase in mortality in these patients as well. If it's stage 3 AKI, 2 out of 3 patients might eventually die, according to the literature so far. And again, there are some differences between different areas in the world, of course. But this is something also relevant to consider. So my overall conclusions to summarize my presentation is mostly do as you normally do. Do not go change something in what you do not have any experience in, etc. The important thing that might be different than what you normally do is anticoagulation, and you might want to intensify that in these patients, one, for their clinical outcome, and also for filter lifespan if it's there. The second thing is that you need to anticipate a surge, and you need to anticipate shortage of material, machines, and personnel, and make a plan how you will handle that. And with that, I thank you for your very kind attention, and I want to thank the faculty of the AKI that actually worked on all these different items, and that's the end of my presentation. Thank you.
Thank you very much, Peter, for a very informative talk. Very useful. I'm sure there will be lots of questions, and I'd like to invite the colleagues listening to the webinar to put the questions in the chat box, and then we will ask them. There may be a bit of overlap between your talk and Antoine's talk, so we should have the bulk of the questions at the end after Antoine's talk. But maybe I could just ask you one question. One is was related to PD and really introducing new techniques. Clearly, this would require a training program, wouldn't it? I don't know whether your nurses are used to doing PD or intermittent hemodialysis in the intensive care unit, and how would you recommend to overcome these challenges?
Yes. So the paper that I refer to is actually also giving some instructions how to anticipate and how to train for it. Because I think it's simple in its nature, but nevertheless, you need to know how to do it, of course. And so we did not come to the point that we had such a shortage of filters that we needed to go there. But I know from people from other places in the world that they did. And the choice is, do not do anything at all and let the patient die, or to do something else. And so my overall message is really important, that overall, do not change something. Don't think well, I've never used citrate, but maybe it's better now. Let's start it in the midst of this pandemic because it's dangerous. You need to, you're too busy, and it's a high risk of making errors and having actually more side effects than benefit. So overall, I say do as you normally do. But if you're really in a crisis and the choice is like letting a patient die because you do not have the machine or the filters, then you have to do something else. And I would suggest actually to collaborate with your people from nephrology departments, discuss this, make agreements on who is doing what, and have people that are experienced in PD as well run this or train the people if you actually come to that phase.
I'm sure that's something we've all learned in the COVID pandemic, that it's so crucial to collaborate with your colleagues and with colleagues outside the intensive care unit. I'm sure there will be more questions, but I think we should just move on to the next talk, and to Antoine's talk, who will cover practical management of renal support at the bedside, and then address questions at the end. And again, I'd like to invite all the listeners to write down their questions and we will ask them. So Antoine, a good friend and colleague of mine, who is an intensive care professor at the University of Lausanne in Switzerland, with a lot of experience in renal support at the bedside. So Antoine, over to you.
Thank you very much, Marlies, for the kind introduction. Thank you, everybody, to be with us during this for this webcast and webinar. Yes, so indeed, I will continue with the practical management of renal support in COVID-19 and try to give you some help and some insights as to deal. And I fully agree with the previous statement made, and I don't think we should completely change the way we practice medicine. Although maybe, at least in Europe, we seem to be perhaps between two waves, and some of the suggestion we might come up would be perhaps things we could implement in the meantime to prepare for the hopefully not, but for the following wave. So I've got a few disclosures that I need to make. And besides that, we can start. And Peter Pickers has done a very nice introduction, so I can go very quickly with the incidence of KI in COVID-19. We all agree it's something that has a high incidence. Obviously, depends on the definition used and the settings. It's definitely a marker of severity, and it's a negative prognostic factor for survival. And again, depending on the centers, on the indications, some of the patients with AKI will require renal replacement therapy, and it's a fairly big proportion of them, and about 10 to 20% will receive this therapy, will require this therapy. And again, like it was already previously said, there's a link between the virus infection and the AKI, and I'm not going to go through all the mechanisms as Peter has already done it, but there's definitely direct toxicity from the virus. There is the cytokine storm and all the inflammation-related issues that are leading to AKI, the hemodynamic and the barotraumatism, the increased intra-abdominal and intrathoracic pressures, the altered hemodynamics, the left ventricular function, etc. And I will insist a little bit more on the last elements, which is definitely an issue in SARS-CoV-2 that we don't face so much with other kind of pneumonias or ARDS, is the coagulopathy. So this coagulopathy in COVID-19 is definitely something that is playing a significant role in the pathophysiology of the disease. Not only contributes to AKI, but to probably the lung issues as well, and definitely contributes to the high mortality of the disease. It's characterized with an increased fibrinogen and D-dimers. Sometimes criteria for DIC are met, but this is rarely the case. And on a more clinical point of view, it can lead to clotting everywhere along the vascular tree, arterial thrombosis with catastrophic consequences, stroke, myocardial infarction, with an incidence ranging between 5 and perhaps 10%. This is not something rare. This is something that we see. And even more scary, or whatever is more scary, but even more frequent at least, is the venous thrombosis, particularly scary when they touch the lung and consist in a large pulmonary embolism. And on top of these, there are some microthrombosis that can be found in the microcirculation that is very difficult to really diagnose and probably play a very important role in the pathophysiology of the disease. And so this microcirculation alteration definitely would be associated with AKI, as well as thrombosis within the kidney. And there is this series of autopsies from China where they were able to demonstrate the presence of intraglomerular thrombosis, really in some of the patient, about 3 in this series of 25 or plus patients. So clearly, thrombosis is part of the pathophysiology of COVID-19, of the disease. It's a link with AKI, and it's something we have to deal with. And again, like was said in the previous presentation, anticoagulation is absolutely mandatory for this patient. We need to give prophylactic anticoagulation to all patients, and probably a bit more than just a simple prophylactic anticoagulation. And when you do renal replacement therapy, you need to be even more. Obviously, there are all these different reasons, and that's in any case, do you have blood circulating an extracorporeal circuit, blood foreign surface contact, a blood pump, you have a relatively low blood flow, you have a treatment that's going on for, aiming to go on for a long period of time. So the circuit is at risk of clotting in the first place, and then you might want to introduce anticoagulation anyway. But when you have a procoagulant state such as COVID, it is all the more important to really administer some anticoagulation. Otherwise, the circuit will really have a very short period of time. So I thank Marlies for sharing these slides with me. This is an electron microscopic of a CRT filter capillary. You can see here, and the virus and the coagulopathy can impair the therapy and lead to clotting, which will completely occlude the lumen and impair the flow, but also to another phenomenon which is called clogging. And this is actually a deposit of a protein cake, so-called, of that is going to create a layer over the surface of the membrane. It will not change the flow within the capillaries, but it will decrease the capacity of the membrane to actually purify the blood. It will decrease its permeability and the ability to diffuse the water. And both these alterations are highly prevalent in COVID-19 due to coagulation alterations. And this is really the last thing you want, because on one hand, you have limited resources, you have limited ability to manage the therapy, and then on the other hand, you have this therapy that is becoming more and more complicated. If you have clogging, it will decrease the efficacy of the therapy. It will generate alarms, and your nurses are going to have to deal with these alarms and to try and fix the problems. And eventually, the filter life will become shorter, and you will need replacement. And again, they will have to work more, and also you have to use more kits, and you already are short of them. So you really want to make everything possible to minimize clotting of your CRT circuits. And here, there's nothing I would say that is really new, because this is something you want to optimize anyway, but it's just something that would be probably nice to have in a normal situation, but that's becoming of particular, really paramount importance in the situation where resources and manpower are limited. Really want to focus on the actual best practice for CRT, which we should try and aim for anyway. So I have several tips that I will argue and propose you to consider. And exactly like it was said in the previous presentation, I don't think we should change everything we do, if you don't know how to use citrate, it's probably not the time in the midst of a crisis to change to that anticoagulation regimen. However, perhaps when you're preparing for a second wave or thinking this could be the time to now move to this citrate, to this anticoagulation, and that is true for all the other different tips that I'm going to give you. So perhaps take that as an emergency thing to change in your unit today, but maybe to implement in a sort of mid to long term. So anticoagulation has been traditionally administered in a conventional systemic way using mostly heparin. And the problem with heparin is that it's associated with a risk of bleeding, and because we don't want our patients to bleed, we tend to underdose the heparin, and the anticoagulation is often inadequate with this regimen. So therefore, regional anticoagulation, such as of which citrate is becoming the prototype nowadays, is becoming a really seductive alternative. And regional citrate anticoagulation is, of course, not associated with the risk of bleeding. It can improve filter life. We get back to that. And it definitely improves circuit permeability because it's a very highly efficient anticoagulation of the circuit. And obviously, as it was already alluded to, it is more complex and it can lead to issues. But the fact is, the literature is, there's numerous publications. These are randomized control trials in different settings using different modes that have clearly established the superiority of citrate in terms of filter life and the much longer circuit lifespan with this modality of anticoagulation. This is data from our center, simply observational, but just to show you that in real life, outside a randomized control trial where you really want to have the best results possible, this is retrospective data, and we simply look at the filter life of all a circuit over a period of 1 year, and we were really impressed to see how much of a difference there was. As you can see, there is almost fourfold. The median duration of the circuit were almost fourfold when the circuit was run in citrate as compared to heparin. And this was essentially due, of course, to a much lower rate of circuit interruption for clotting, and is translated on a much higher dose per session. So much longer filter life with citrate, less complications, less downtime, and eventually, if you put this all together, lower costs. And again, this is not new. This is not something that's special for the COVID, but this is something that's been recommended by the KDIGO Society already in 2013, so 7 years ago. So we should all move to these technology or to these modalities that are just what we probably should be doing anyway. And citrate is really the way to go, and it's all the more important when you're facing these situations. Again, there can be complications, and this is not something to move to do lightly. And the number one complication is citrate accumulation, although very rare. And in certain circumstances, really, those patients that have really circulatory shock, very refractory, and perhaps liver failure, but very severe, or poisoning. But that occurs really rarely if you're following a real strictly validated protocol. You can't just start doing citrate and think you know. You need to be really following a protocol. And this protocol should be really aiming at using a lowest possible blood flow. Because as you probably know, citrate is always, the administration of citrate is linked to the blood flow. The more blood flow, the more citrate, and the more citrate, the more likely it is that your patient might have accumulation of the molecule. And then if you are a center with low experience, what you might want to do is start with the citrate for those patients that really have no risk. Patients, no shock, no problems of liver, no issues. And if you really limit your patients, your indication to those patients, then you're probably safe in the vast majority of the patient. Follow, monitor the calcium, the total over ionized calcium ratio, and it's extremely important to do. So that's the first tip, is use regional citrate anticoagulation with as much as possible, move towards this utilization. The second one is also consistent with what's been said, is use CVVHD. And again, this is not something that's specific to the COVID, but it is probably something that's really better for filter lifespan. And simply stated, when you use hemofiltration, so the pure hemofiltration, the CVVH mode, you will have some form of hemoconcentration by definition, because what you will do is filter the plasma, remove some water and electrolytes, and this will progressively lead to a concentration of the blood, and you will have an increased concentration of the platelets, of the coagulation factors, and that will lead ultimately, if you do that too much, to clotting. Obviously, there are workarounds. You do pre-dilution, you have a high blood flow, but clearly, you need to keep the filtration fraction, the ratio of filtration over the blood flow under 20%. That implies the highest possible blood flow, but at a given dose, it's not always easy to have a very high blood flow, especially if the patient has shock or he's hypovolemic or the catheter is a problem. So it's complicated. These issues never happen in CVVHD mode, simply because filtration fraction is only limited to that of the fluid removal that you affect, the net fluid removal that you want to achieve. So it is never going to be a problem in this mode. There's other advantages of using CVVHD is you can very effectively run the therapy with very low blood flow, 100, 120 mils per minute instead of 250 in CVVH mode. And again, that would mean you're going to have to use less citrate. You will put less strain on the catheter. You don't need to use pre-dilution, because the pre-dilution is only there to counteract the effect of hemoconcentration. You should not be worried about the clearance, because at least for the small molecules and the urea, creatinine, all the molecules that we really want to clear with the CRRT, is the clearance is exactly similar between the two modality. And on top, because there's less filtration, there's going to be less clogging, less protein cake formation. So all good reasons to prefer this modality and particularly in this setting. Then there's something that may be more of a user tip that really supported by the literature is in case of the clotting, you might want to consider high cutoff membranes, and you have so we all use high flux filters nowadays, but there are some high cutoff membranes that have actually been marketed mostly to enable middle molecule clearance, and hopefully in the hope of improving again treating the cytokine storm. And you can see here the clearance of small molecules is essentially not different, but those of the larger molecules like myoglobin or IL-6 is higher in these high cutoff filter. So that's not the reason why I would suggest that you use it, but sometimes, and not in all patients, you might experience early clogging of the circuit, even with citrate anticoagulation. And in my experience, we found that using these high cutoff membranes in these situations were improving the situation in some case. So again, that's mostly a user tip. The next one is consistent with what's been said. It's optimizing vascular access, and we can't repeat that often enough, that the most important component of the CRT circuit, the best anticoagulant for a circuit, is the catheter. If you have a dysfunctioning catheter, you can put all the heparin, all the citrate that you want your circuit will clot, and it will not work because the hemodynamic is wrong. So the vascular access and needs to be of a certain size, but again, if it's going to be partly clotted, the bigger the better, and of course the flow is proportional to the resistance to the flow is proportional to the diameter. So you want the widest catheter as possible that you can obtain, and at least I would recommend 12 French. The right material, the right design, put it in the right vessel, and most importantly, care about the catheter. Think about the catheter if something goes wrong with the circuit. You're better off replacing a line earlier than later, because you will eventually save some time. Then when we talk about catheter in COVID, there is this option. A few of our patients, thank God, there's only a limited number of our COVID patients that require ECMO, mostly VV ECMOs. And this is a connection that we can consider. It's not something I would necessarily recommend to use as a default. Some centers are doing that, and it depends on your experience, but you can consider that if you really have issues with the catheter in some patients where you cannot put a regular catheter. There's different way to connect these catheters. In my center, we really try to use it as a last resort only, and only if we cannot find any other alternative vascular access. And I guess here the most important thing is really to follow again a strict protocol and to really clarify who between the nurse and the perfusionist is doing what to avoid major complications. And again, all CRT machines are not able to connect to the high pressure environment of an ECMO or negative pressures. So you need to decide on the setting based on your local equipment. And then this is also where I would like to stress that you can consider to use different modalities that you normally use. I like to say that intermittent hemodialysis is like a Formula One. It's extremely powerful. It can deliver the equivalent clearance that we need over 24 hours in less than 3 or 4 hours. So you only need to apply the therapy once or twice every day or every other day. And obviously, in periods like you have doubling or a tripling of your number of patients, then it might increase the number of patients you might treat per day. You also don't absolutely need anticoagulation. You probably will need to give some, but at least you don't have to be so worried because the circuit will not last as long as CRT. And it's less of an issue, let's say, but it also requires some trained staff. It's also required some technical practicalities. You might not be used to using this modality. And again, this is not something, but often this modality is applied by nephrologists, even for outpatient clinics. So maybe this is perhaps easier to implement in the time of a crisis than some other RT modality. And perhaps this is time to rediscuss hybrid solutions and techniques like SLED or high-dose CRT for a shorter period of time. These things that have a little bit fallen outside the main scope in the majority of units, but perhaps this is time. In my center, we didn't have to eventually, but we considered moving to high-dose CRT and treating 2 patients with a single machine if we had the need for that. And the last thing that you can just discuss is adjunct therapies. When you have a CRT device, you have access to the blood, and there is this theory, this up-and-coming possibility of providing multi-organ support with the CRT platform. And so support not only the kidney, but also the heart, the lung with the extracorporeal CO2 removal, the liver, and particularly in the context of COVID, remove some cytokines. And one of the possibilities to use these cartridges of generating hemoadsorptions that would undifferentially remove all sorts of mediators, inflammatory mediators, but also cytokines, anti-inflammatory cytokines. This is obviously something quite new experimental, that what we can say it's easy to do. You can just plug it into the device and it's relatively safe, at least on the short term. There's a rationale for it. We've seen that perhaps dexamethasone or tocilizumab, which have a sort of similar rationale, seem to improve the outcomes of the patient, but obviously before it gets generalized to its utilization should be tested in clinical trials. And the same comment applies for ECOR. ECOR is an attractive idea, and it's really nice to be able to support the ventilation with the CRT device. The main limitation is that you really, to have some form of meaningful CO2 removal, you need to have a very high blood flow, which then prevents the utilization of citrate for the thing we've discussed above. And also there's no evidence that it actually really improves the outcome of the patient. So it should be tested as well in clinical trials. So that brings me to my conclusions. And in these situations of limited resources, it's all the more important to optimize CRT, to minimize the staff workload and to optimize resources. And something we haven't really discussed actually, but that is central to this discussion is to really select the right patients that would benefit from the therapy, and also the right timing for initiation. You might be maybe more liberal or more selective in your center, but I think you need to rediscuss these inclusion. It's true we should do as much as possible what we do normally, but you might want to not even rationalize care, but at least just be a bit more careful, perhaps wait a bit longer if you're in the early kind of units. And when you do CRT, you can optimize it by utilizing citrate regional anticoagulation, CVVHD mode. Make sure you have an adequate access, replace it as soon as you have issues with it. Consider these high cutoff filters if they're available in your units, especially if you have these early clogging issues. And also consider talking to a nephrologist and bringing some intermittent dialysis machine, or do some form of hybrid therapies with your CRT devices. And again, if you have them and if you think this is the right thing, you can consider adjunct therapies, and particularly in special situations. Thank you very much.
Thank you very much, Antoine, for an excellent overview. Not surprisingly, there are a lot of questions now in the chat box, and I will try to summarize them and put them together. So we had questions related to the fact that I think, Peter, you said volume depletion is a common cause of AKI, or can be a cause. Mm-hmm. And the question is, how do you assess fluid status, volume status in patients with COVID? And it has a follow-up question from somebody else, which I will add, which says, so how do you set fluid balance in patients with AKI, in particular those who need renal replacement therapy?
Yes, it's a relevant question, and I think assessment of volume status is the one thing in intensive care medicine that is really difficult, and we have to deal with it every day. So I guess there's nothing that's special on COVID, and that we should do what we usually do. So from passive leg raising to pulse pressure variation, etc., the usual measures to give us an idea on what intravascular volume is and if a patient needs fluids. The issue in the COVID patients, of course, is because they're so compromised for their lungs that people are really reluctant to give fluids to them. And that might be good in most of the patients, but there are definitely some patients that might suffer from that if, for example, the kidneys suffer from dehydration. So my message would be use the same thing that you do always to try to have an idea of the volume status of that given patient. And if needed, and if you think that dehydration might play a part in the AKI that you see in that patient, then you should consider being reluctant with fluids or giving some fluids for the kidneys.
Thank you very much. I have a question for Antoine. And I think, Antoine, you highlighted CRRT. But the question was, is there evidence that CRRT is superior compared to intermittent hemodialysis or PD in COVID?
Well, not that I know of. I mean, I don't think there's any comparison that's been undertaken. And again, I think everybody should stick to the modality. I think the topic was mostly to discuss CRT because this is commonly used in many ICUs, but obviously I touched on intermittent dialysis. So no, there's no evidence. I mean, we can say that overall, outside COVID, there's no evidence that either mortality is superior in terms of mortality. There is some data suggesting that perhaps fluid balance control could be easier with the continuous modality for obvious reasons. You have if you want to remove fluid to a patient and you have to do it over 4 hours, it's going to be more dramatic than if you have to do it over 24 or 48 hours. And then you might lead to complication. You might be, maybe you don't dare remove as much fluid because you're not going to be able to do it, or the patient might not tolerate, so you're more careful with the fluid removal, or you do it anyway, and then you might harm the kidney even further and decrease the potential to recovery. So I think this is the advantage of continuous, is having this fine tuning for fluid balance control during the therapy, but there's no real evidence to support this.
Great. Then we have quite a few questions which relate to cytokines, cytokine removal, blood purification. And maybe if I summarize them, the first question, one question is there a role for blood purification and removal of interleukin? And maybe, I think, Peter, you may be the right person for this, given your general interest in this topic.
I think, so what we see in these patients, indeed, that there are elevated levels in the blood of inflammatory mediators. And also that this concentration is related to outcome. And that is logical. The more sick you are, the higher the levels, the worse your outcome. That association does not mean per se that if you do something about these levels by, for example, blood purification filters, that you would improve outcome. So I think the theoretical basis is there, but we have no data to show that there's any benefit on clinical endpoints. And so I am afraid at this moment, the statement that we can only make is that we urgently would need data of patients in a way that is actually open to interpretation. So that means that you need a contemporaneous control group, and not just show that if you put them on the filter that their cytokines or other inflammatory mediators go down, because that happens anyway. But you need to show if they go down to a greater rate or if there's any sign of clinical benefit. That's one thing. And the other thing that might be side effects of these filters is that this is not related to renal replacement therapy. So that means that you would need vascular access. You would need a machine. There might be shortage of machines. And it's not necessary for renal replacement therapy. So it's difficult and dependent on the local situation if you would be able to do so. But my view is at this moment that there's no evidence of clinical benefit so far, unfortunately.
Antoine, there's a question which relates to this. And the question is there a role for the auxiliary membrane in COVID-19?
So again, this is I don't think there's any data supporting auxiliaries in this situation. It's a very similar rationale. It's another. So I mentioned the cytosorb, and I showed the slide. There are other blood purification devices, and I fully agree with Peter's statement. There's no data supporting any of these modalities. So in my unit, we haven't really used it. So it's something that is, again, theoretical, and it is worth thinking about, but I would not suggest as a recommendation to use it as a regular. Some units will use these kind of device in a regular basis, so they're free. I mean, it's available, it's on the market, but I don't think, again, that there's strong evidence that, actually even any evidence that we should be using it in patients with COVID.
Could I give you a follow-up question, Antoine, because you touched on PD, and the question is there any evidence of interleukin clearance during PD?
I'm not aware of. I don't know how to respond to this question. I don't use peritoneal dialysis, and I don't have. So cytokine clearance, I don't know. I can't respond. Maybe Peter can help.
Peter,
No,
do you
there's
know?
not. No, there's no evidence of that, and I think that we know from normal conventional renal replacement therapy that the effect on cytokine clearance is also very, very limited. And so if you compare that to these specific blood purification filters. And maybe also of relevance for the people that are watching is that it's really important to realize that there are different kinds of filters for blood purification, and they have different properties. So there's some that focus on removal of cytokines, like the cytosorb, some of removal of endotoxin, like the PMX filter, and the Oxiris filter that was mentioned actually does a bit of both, and also is a renal replacement therapy filter, which the other ones are not. And there's also another filter of Xtera that's also able, and they showed that in vitro, that's able to remove the virus from the blood. And so we do know that a very small proportion of patients do have RNA in their blood circulating. So maybe there is a subgroup that might benefit from it, but we do not know what the clinical benefit would be.
Thank you both. Could I, hot off the press, a question related to the fact that we've had some positive trial results with dexamethasone. And the question is, are you aware of any role for steroids in COVID-associated AKI?
Who do you want to
It's a
answer?
little bit off the topic. It's not really related to renal support, but obviously it is important because if we reduce AKI, then we don't have a problem with the challenges of renal support anymore. So
yes, my view is I think it's really worthwhile to look into the data of the trial and to see what the effects are on developing AKI. So you have to look at patients that come in with AKI. Maybe there's an effect on how many of these patients will need renal replacement therapy. And there are patients that come in with no AKI or stage 1, and you can follow up what will be their development of AKI. And as I showed in one of my slides, we do think that the inflammatory response might be responsible of part of the AKI. And so if you give steroids early and you influence that inflammatory response, there might be an effect on the kidneys. That's true. But it would be worthwhile to look into the data. It's a large trial. If there is specific data on the kidneys, and to see if where there is a benefit. And if there's a mortality benefit, that means that there should be a benefit of organ dysfunction. Otherwise, there would be no mortality benefit. So it's really worthwhile, I guess, to look, is this something that's working on the lungs? Is it something that's working on the kidneys predominantly that is responsible for this survival benefit?
Thank you. Now we have overrun slightly, but I'd like to give you a final question, both of you. And the question is, what have you learned in the first wave of the COVID pandemic, and how do you prepare for the next one and the potential renal? I don't know who wants to start. Antoine?
Yeah, so what I've learned is, I think like everybody, I learned to be prepare for the worst, hope for the best. And it was really a very, very anxious times where you didn't know, and we still don't, by the way, but you didn't know. We all talk about this wave. We don't know how high, and you don't know how long. So this was the question, and be really humble and work as a team. I think it really reinforced our team here inside the ICU, but also with other specialties, and learn that we can work together. And when you go over this rivalry, these fights, these discussions and everything endless, you can be so efficient, and we've achieved so much in so little time. This is really what I'm going to take away from this COVID period. yes, we are maybe expecting a second wave, maybe preparing for a second wave. We don't know. So what we have changed, and this is pretty much what the flow of my presentation. We are trying to, when you talk about renal replacement therapy, we're always aiming to have optimal therapy, and this is what you want to do anyway. But this shortage really stressed that there are things that we need to improve, and we need to move towards this model that I described to optimize this part. And it's not the only part of the course of the therapy, but when we talk about CRT, you want to optimize and to minimize the consequences for the patients.
Great, thank you. And Peter, how do you prepare for the next renal challenge?
I think two things. The one thing is anticoagulation. I think in the beginning we burned a lot of filters and we already had a shortage. And then we started to intensify it, and then we found that indeed filter lifespan could be as usual if you intensify anticoagulation. And the second thing, I agree with Antoine. I think people that are intensivists and work in the ICU want to do it all themselves. That's our nature, I guess. And we really have to learn to delegate and ask others for help to be able to efficient ourselves as much as possible. And so indeed, we had teams that would turn the patient, and we had our colleagues from anesthesiology would actually do all the transports between the hospitals, what we normally do. And so this helped a tremendous lot. And I think we could take that one step further and have people helping us out, and so that we can focus on very specific intensive care issues.
So on behalf of the European Intensive Care Society, I'd like to thank you both for excellent talks and sharing your experience. Given that it's a new disease and we're still learning, it's a disease which is now 5 months old, but we have learned a lot, and I'm sure there is more to learn. So sharing your experience has been very, very useful. Thank you. And I'd like to thank the European Society of Intensive Care Medicine for organizing this fantastic and very useful webinar, given the challenges in the last few months. Thank you. Enjoy your afternoon, evening, morning, wherever you are. And thank you to everybody, including the technicians who helped us with the webinar.